The best reconstruction is not the most elaborate operation. It is the least burdensome repair that reliably solves the exact cancer-free defect. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Wait a second. Hold on. If all we really need is a cancer-free defect, why not just pull the hole closed immediately and call it a day? Doesn't the absolute shortest scar automatically equal the best outcome for the patient?
Which brings us to Section 1, clearance before definitive reconstruction, or what we call the oncologic priority.
So the foundational rule of this entire process is that oncologic clearance absolutely has to come before any definitive tissue rearrangement. We're treating the reconstruction as a second, completely linked decision that only kicks off once the cancer question is fully resolved. We map things out, sure. We plan our branches before the Mohs surgery even starts, evaluating the patient, looking at prior treatments, anticipating needs. But we only commit to a definitive repair branch once we know those precise margins are clear. Why? Because if you go in and do major undermining or throw down a complex flap before confirming clearance, any leftover tumor becomes an absolute nightmare to track and remove later on. And that brilliantly illustrates why just pulling a hole closed isn't always the magic fix. A final surgical defect has to be analyzed far beyond a simple surface diameter measurement. You literally cannot just look at a wound, measure it with a ruler, and let that one single number dictate your repair.
The crucial point here is that we must evaluate the defect across 6 distinct dimensions. First up, surface geometry. Think shape and tension lines. Second, depth and missing layers. Slopping some skin on top doesn't do you any good if you're missing the structural cartilage or mucosal lining underneath. Third, free margins and functional units. If you pull tissue on the cheek, you might accidentally drag down an eyelid or distort a nostril, right? Fourth, local tissue mobility and tension vectors. Fifth is blood supply and tissue quality, which is especially important in radiated or scarred skin. And finally, the 6th dimension, the host and their care environment. A patient's medical stability and their actual ability to perform wound care fundamentally change our reconstructive choices. A basic surface coverage just cannot compensate for an absent structural framework or a loss of function.
Okay, but if the defect is really that multidimensional and complex, shouldn't a surgeon just mechanically climb a reconstructive ladder? Start with the absolute simplest closure and only move up to a complex flap if the simple one fails?
That perfectly introduces Section 2, the reconstructive elevator and problem-matched selection.
Historically, yes, surgeons were taught to mechanically climb this rigid reconstructive ladder, but a way more accurate model is the reconstructive elevator. Instead of rigidly climbing rung by rung, the surgeon analyzes the exact problem and takes the elevator straight to the floor they need. Honestly, a complex flap might actually be way less burdensome overall than trying to force a high-tension linear closure that ends up distorting a patient's lip or eyebrow. Different repairs are just tools. They are completely devoid of a universal hierarchy. Second intention healing, a planned linear closure, a local flap, a full-thickness graft. They all solve specific problems, but they also carry distinct failure modes that you have to anticipate. For instance, second intention avoids creating a donor site entirely, but on the lower leg it might heal painfully slow and carry a real infection burden. A full-thickness skin graft avoids distorting local tissue, but it depends entirely on the recipient bed's blood supply. A local flap brings its own blood supply and can redirect tension, but you risk the trapdoor effect or pinch cushioning. The correct technique is always the one that solves the dominant defect problem with the absolute lowest total burden.
Right, I get the elevator concept in matching the tool to the defect. But if there's no set hierarchy and these wounds are all uniquely complex puzzles, how do we know if it's actually safe to perform these highly diverse repairs, especially in an outpatient setting? What does the safety evidence actually show us?
It's a vital question. And to answer it, we have to look at a massive prospective multi-center cohort of over 20,800 Mohs procedures. The investigators recorded an overall adverse event rate of just 0.72%, with 0 deaths and 0 permanent disabilities. This gives us incredibly strong aggregate reassurance for Mohs procedures and outpatient dermatologic surgery.
However, we've got to caveat that statistic immediately. That 0.72% is a broad overall safety net. It does not erase the specific risk profile of an individual complex repair. It simply doesn't predict the complication rate for one massive flap, a delicate structural graft on an irradiated field, or a high-tension closure on a patient's lower extremity. The risk of the procedure must travel with the specific feasibility of that exact repair.
Let's transition to Section 3, timing and operative setting, immediate versus staged.
This brings us to a major variable. When should the reconstruction physically take place? We naturally tend to assume everything happens in one go, but a Trinex analysis covering over 600,000 Mohs cases found that 19% actually had no same-day repair code. Now, that doesn't mean those cases failed. It just proves that while same-day repair is incredibly common and efficient for many defects, it is absolutely not mandatory.
Leaving a wound to heal by second intention, purposefully delaying the repair, or staging a complex interpolation flap over several weeks, these are deliberate reconstructive techniques. It is not indecision. We might delay because we're waiting for conventional pathology to clarify a tricky margin, or maybe we're allowing a wound bed to evolve before placing a graft. It could also be about optimizing a patient's medical status or coordinating with another surgical specialist.
But logically speaking, if a patient requires a delayed repair or they're going through a multi-stage flap, shouldn't they just automatically be prescribed antibiotics to prevent infection? And shouldn't they definitely stop all their blood thinners just to be safe before these procedures?
You know, it's really tempting to think a complex repair means throwing the kitchen sink at the patient preoperatively. But narrow trials simply do not justify universal prophylaxis. Decisions about antibiotics and antithrombotics must remain strictly patient, site, and repair specific. For instance, the prospective Regis Mohs cohort showed that while blood thinners were associated with a small increase in hemorrhage, it generally didn't justify routine withdrawal when you factor in the stroke or clot risks of actually stopping them. Likewise, a randomized trial showing a single dose of antibiotics reduced infections for very specific complex nose and ear repairs does not mean every single Mohs closure across the body needs routine antibiotics.
Moving on to Section 4, Interpreting Safety and Outcomes and Prioritizing Function Before Appearance.
This leads us perfectly into how we actually define a successful reconstructive outcome. We have to separate short-term cosmetic judgments from mature functional outcomes. Form and function evolve. Appearance simply shouldn't be definitively judged in those first few postoperative weeks. Edema, erythema, firmness, and scar contraction evolve over many, many months. In fact, patient-reported aesthetic satisfaction and overall quality of life continue to improve through an entire year after Mohs surgery. Function has to be prioritized before appearance every time.
And this brilliant distinction helps us be incredibly careful when reading studies that claim one technique is definitively better looking than another. Observational cosmetic comparisons are strongly confounded by both the defect itself and by surgeon selection. We can't definitively rank a flap over a graft universally, because surgeons intentionally select flaps for entirely different wound depths, locations, and tissue mobilities than they do for grafts. Because treatment assignment isn't random, the fact that something is feasible in one study does not prove universal superiority for all wounds.
This is also exactly why collaboration is so vital. Referring to another specialist should always be about adding a necessary capability or a specific anesthesia setting that the primary surgeon just doesn't have, like complex posterior lamellar eyelid reconstruction, intricate airway work, or needing general anesthesia. It is not about a categorical specialty superiority.
So pulling this entire framework together, when a patient and clinician are sitting down, faced with a complex, multidimensional defect, what is the absolute most critical takeaway to ensure the best possible outcome?
It really boils down to this clear, three-step decision pathway. First, unequivocally confirm oncologic clearance. Second, analyze the multidimensional defect for exactly what structural and functional layers are missing. And third, take the reconstructive elevator directly to the least burdensome viable option that restores form and function. But once that immediate repair is chosen, how do these choices actually impact long-term scar management? We're going to explore that in our next Skin Trust question. For now, I highly recommend reading the complete explainer online to discuss these individual decisions directly with your treating clinician.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clear decisions together.